Bismillahirrahmanirrahim. Let's begin with the quote of the day. Your hardest times often lead to the greatest moments of your life. Keep going through. Tough situations build strong people in the end. The topic I'll be presenting today is rheumatic fever. I'll be giving this presentation under the kind supervision of my most honorable and most respectable supervisor, Professor Dr. Sara Afzal. Learning outlines are introduction to rheumatic fever, problem statement, etiology, pathogenesis, signs and symptoms, treatment, levels of prevention, recent updates, and MCQs. Learning outcomes. At the end of the presentation, participants would be able to describe rheumatic fever, its epidemiological factors, sign and symptoms, complications, treatments, and prevention and control. Starting with the problem statement, what is the global incidence of acute rheumatic fever? In developing countries, the magnitude of acute rheumatic fever is enormous. Recent estimates suggest that 33.4 million people worldwide have rheumatic heart disease and that 3 lakh to 5 lakh new cases of rheumatic fever, approximately 60% of whom will develop rheumatic heart disease, occur annually with 230,000 deaths resulting from its complications. Almost all of this toll occurs in the developing world. The incidence rate of the rheumatic fever is as high as 50 cases per 1 lakh children in the developing countries. As far as the stats of Pakistan are concerned, the prevalence of rheumatic heart disease in Rahim Khan sub-district is 5.7 in 1,000. Assuming that this is the rate of rheumatic heart disease throughout the rural population of Pakistan, 88 million, there are more than 5 lakh patients with rheumatic heart disease in rural Pakistan. Starting with the introduction, rheumatic fever, a delayed autoimmune reaction in generally genetically predisposed individuals to group A beta hemolytic streptococcal pharyngitis characterized by inflammation of several tissues that give rise to the typical clinical manifestations including carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules, residual damage only in the heart, latent period of 3 weeks, and 3% to 6% of any population. Etiology. Acute rheumatic fever is a systematic disease of childhood, often recurrent, that follows group A beta hemolytic streptococcal infection. It is a delayed non-suppurative sequel to upper respiratory tract infection with group A beta hemolytic streptococci. It is a diffuse inflammatory disease of connective tissue, primarily involving heart, blood vessels, joints, subcutaneous tissues, and CNS. Epidemiology. Age 5 to 15 years are most susceptible. It is rarely present in less than 3 years of age. More in girls as compared to boys. Common in third world countries. Environmental factors involve overcrowding, poor sanitation, poverty. Incidence is more during fall, winter, and early spring. Pathogenesis. Delayed immune response to infection with group A beta hemolytic streptococci. After a latent period of 1 to 3 weeks, antibody-induced immunological damage occur to heart, valves, joints, subcutaneous tissue, and basal ganglia of the brain. Group A beta hemolytic streptococcus. Strains that produce rheumatic fever are the M types 1, 3, 5, 6, 18, and 24. Pharyngitis produced by group A beta hemolytic streptococcus can lead to acute rheumatic fever, rheumatic heart disease, and post-streptococcal glomerulonephritis. Skin infection produced by group A beta hemolytic streptococcus leads to post-streptococcal glomerulonephritis only. It will not result in rheumatic fever or carditis. Features suggestive of the group A beta hemolytic streptococci infection. The patients are mostly 5 to 15 years of age, presentation in winter or early spring. There would be fever, headache, sudden onset of sore throat, nausea, vomiting, abdominal pain, pain with swelling, beefy swollen red uvula, soft palate petechiae, donut lesions, tender enlarged interior cervical nodes, tonsillopharyngeal erythema, and exudates. Group A beta hemolytic streptococcus. So yeah, I've explained it about this. Now you can see there is a pictorial representation of the rheumatic fever. There is you can see the joints, heart, skin, and nervous system. So pathophysiology. The causative agent is the group A beta hemolytic streptococci, untreated streptococcal throat, rheumatic fever. All layers of the heart and the mitral valve become inflamed, vegetation forms, and valvular regurgitation and stenosis, and then there will be heart failure. Clinical manifestations of acute rheumatic fever are polyarthritis, carditis, erythema marginatum, chorea, subcutaneous nodules, and so on. So the carditis, starting with this, there would be incidence that varies from 50% to 60%. The clinical diagnosis of carditis is an index attack of rheumatic fever. It is based on the presence of significant murmurs, pericardial rub, unexplained cardiomegaly with congestive heart failure, common in the young, and 80% of the patients develop it with first 2 weeks of rheumatic fever. Endocarditis, almost always used with the murmur of alveolitis, an universal finding in rheumatic carditis, whereas the presence of pericarditis or myocarditis is variable. Involvements are 92 to 95% mitral valve involvement and 20 to 25% aortic valve involvement. Pericarditis, 6 to 15% of the rheumatic fever diagnosed by typical pain and friction rub. Always associated with rheumatic valvulitis, may be associated with normal ECG, may be associated with effusion, but rarely causes constriction and tamponade. Its presence denotes the severe carditis. Polyarthritis is 66 to 75% of the patients would be affected. Most common and most earliest manifestation typically involves larger joints, knee, ankle, wrist, and elbow. Involves joints hot, red, swollen, and tender, migratory in nature, not deforming, a dramatic response to small dose of the salicylates. Subcutaneous nodules, they are rare, 2 to 20% freely mobile, painless, 0.5 to 2 centimeter, occur in crops over bony prominences or extensors or tendons. Common locations, elbow, wrist, knee, ankle, and Achilles tendon. Erythema marginatum is 3 to 15% erythematous serpiginous macular lesions with pale centers that are not pruritic. Multiple lesions primarily on the trunk or proximal extremities, rarely on distal extremities, and never on face. It occurs early in course of rheumatic fever. Erythema marginatum is non-painful, non-pruritic, blanches on pressure, accentuated by the warming by warming the skin, not influenced by anti-inflammatory therapy. It is associated with carditis. Nodules and marginatum can occur simultaneously. It is also seen in sepsis during reaction, glomerulonephritis. Chorea, Sydenham chorea is 5 to 36% of acute rheumatic fever. It is more common in females, rarely present in more than 20 years of age. Isolated, frequently subtle neurological behavior disorder, emotional lability, incoordination, poor school performance, uncontrollable movements, and facial grimacing. It is exacerbated by stress and disappears with sleep, seen occasionally unilateral. So you can see here a pictorial representation of the Sydenham chorea. The minor manifestations include arthralgia, which constitutes pain in one or more joints without evidence of inflammation, tenderness to touch, or limitation of motion. There is arthralgia along with monoarticular arthritis, and it is suggestive of the rheumatic fever. Fever, there would be temperature more than 100.40. Rectally diurnal variations are seen. Children with mild carditis and patients with chorea are afebrile. Epistaxis seen in 4% of cases. Abdominal pain, 5% of cases occur before the appearance of major manifestations. Pain usually epigastric or periumbilical and may mimic appendicitis. Evaluation of the Jones criteria and original Jones criteria of 1944. The major manifestations are carditis, arthralgia, chorea, subcutaneous nodules, and there will be history of previous definitive rheumatic fever or rheumatic heart disease. Minor manifestation includes fever, abdominal pain, precordial pain, rashes, epistaxis, pulmonary findings, lab findings, ECG, microcytic anemia, elevated DLC, and raised ESR. Jones criteria, the updated 1992 version. Major manifestations are again the carditis, polyarthritis, chorea, subcutaneous nodules, and erythema marginatum. And the minor manifestations include the prolonged PR interval, fever, arthralgia, lab findings, elevated acute phase reactants, increased ESR and CRP. Along with these two, there would be supporting evidence of preceding streptococcal infection, positive throat culture swab for group A streptococcus, or rapid antigen test elevated or rising streptococcal antibody titer. The rheumatic fever criteria, the mnemonic is John's Cafe Paul. So the major and the minor criteria, J stands for joint involvement, O looks like a heart myocarditis, N is for nodules, E erythema marginatum, C S Denham chorea. For minor criteria, C stands for CRP increased, A arthralgia, F fever, E elevated ESR, P prolonged PR interval, A amnesia of the rheumatism, and L for leukocytosis. So for diagnosis, throat cultures, growing group A beta hemolytic streptococci or elevated anti-streptolysin, O titers, two major criteria or one major criteria or two major criteria. So the major criteria and the minor criteria, as you know, that erythromarginatum is 2 to 10%, carditis is 45% to 70%, skin nodules 2%, 20%, serum chorea 10%, migrated polycystitis 75%. So the first episode of the recurrence without established heart disease, 2 major criteria or 1 major or 2 minor criteria, and the absolute requirement, recurrence with established heart disease, 2 minor criteria and the absolute requirement. So that would be the criteria for the acute rheumatic fever and rheumatic heart disease. Lab diagnosis of acute rheumatic fever, there is no gold standard diagnostic technique. Throat culture swab, initially considered a gold standard for diagnosis of streptococcus infection. Limitations, the first one is difficult to differentiate a carrier from the active infection. Second, 1/3 of the rheumatic fever has no history of preceding pharyngeal infection. Third, delayed in getting culture report. Lab diagnosis of the acute rheumatic fever, rapid antigen test from throat swab. Specificity is 95% and sensitivity is 60 to 90%. Streptococcal antibody test is anti-streptolysin ASO, anti-DNase, anti-hyaluronidase, and streptozyme. ASO test, significant antibody response defined as a rise in titer that is more than 2 dilution increments between acute phase and convalescent phase. Serum samples obtained 2 to 4 weeks intervals. ASO titer of more than 240 to add units in adults and 320 to add units in children. 5 years is elevated, appears 7 to 10 days after the infection, with peak detection and 2 to 3 weeks after the onset of rheumatic fever. Echocardiography advantages are superior sensitivity in detecting rheumatic carditis. The misdiagnosed avoids misdiagnosis. Disadvantages are overdiagnosis of physiological valvular regurgitation as an organic dysfunction. Echocardiography facilities not widely available. Ability to detect the recurrence of subclinical subcarditis not clear. Echomyocardiography, echomyocardial biopsy. Aschoff nodules or histological aggregates considered diagnostic of rheumatic myocarditis. Sensitivity is 43%, specificity is 100%. Myocyte degeneration usually without lymphocytic infiltration and frequent without the Aschoff nodules. Do not provide additional diagnostic information and is not recommended. Levels of prevention. Primordial prevention includes a range of improvements to living conditions that reduce poverty and overcrowding in populations at risk of acute rheumatic fever and rheumatic heart disease. There have been dramatic reductions in the rates of acute rheumatic fever and rheumatic heart disease in populations that have experienced improvements in socioeconomic and environmental conditions. Primordial prevention, improvement in socioeconomic status, prevention of overcrowding, improving nutritional status, availability of prompt medical care, public education regarding. The primary prevention includes primary prevention of rheumatic fever, group A streptococcus. Infections of the pharynx are the precipitating causes of the rheumatic fever. Poor diagnosis and adequate antibiotic treatment of group A streptococcal infections can prevent acute rheumatic fever in most common cases. The treatment of rheumatic fever, the step 1 includes the following drugs, that is benzathine, penicillin, there would be erythromycin, and so on. So you can check here the treatment of rheumatic fever includes the following drugs, and according to the ages, there are the doses mentioned here. So you can see all of the doses accordingly. The penicillin G, there would be, that is given by per orally, benzathine, penicillin, that is by injection, and so on. So for arthritis, you can give aspirin, that is 75 to 100 milligram per kg per day. It is given as 4 divided doses. Then there's carditis, that is prednisolone, can be given for this. That is anti-inflammatory treatment as step 2. Treatment includes post-treatment throat cultures 2 to 7 days after completion of therapy are indicated. If patient remains symptomatic, whose symptoms reoccur, patients who have had rheumatic fever and are therefore not unusually high risk for the recurrence. Treatment failure, a second course of therapy in asymptomatic individuals should be considered only for those with previous rheumatic fever themselves or members of their families. Treatment required if symptomatic. Treatment of carriers, chronic streptococcal carriers defined as individuals with positive throat cultures for group A streptococcal infection without clinical findings or immunologic response to group A streptococcus antigens usually do not need to be identified or treated with antibiotics. Secondary prophylaxis is the administration of antibiotics to people with a history of rheumatic fever to prevent group A streptococcal infection, subsequent rheumatic fever recurrence, and to minimize progression to rheumatic heart disease. Secondary prophylaxis includes the drugs like benzathine, penicillin, and sulfadiazine, penicillin, V, and so on. So the WHO criteria for secondary prophylaxis includes patient without prevention carditis. That is, for 5 years, we have to, for 5 years after the last attack or until 18 years of age. Patient with carditis for 10 years after the last attack or at least until 25 years of the age. More severe valvular disease lifelong. After wall surgery, they would be the condition will be lifelong. So prognosis, rheumatic fever can reoccur whenever the individual experiences new group A beta hemolytic streptococcus infection, if not on the prophylactic medicines. Good prognosis for older age group, if not carditis during the initial attack. Bad prognosis for younger children and those with carditis with valvular lesions. The provision of catheter-based and wall surgery to prevent morbidity and mortality from cardiac damage that has resulted from acute rheumatic fever, reduced morbidity, financial burden, inactive endocarditis prophylaxis, prosthesis wall disease, and lifelong anticoagulation. Rheumatic heart disease is a major cause of morbidity and mortality in low and middle income countries and among underprivileged communities in high income countries. Primary prevention of the acute rheumatic fever requires adequate antibiotic treatment of streptococcal throat infections. Secondary prevention entails prevention of recurrent episodes of acute rheumatic fever and is the most effective way of preventing rheumatic heart disease. Corticosteroids do not reduce the risk of developing heart wall lesions after 1 year. Surgery may be a life-saving measure in patients with acute rheumatic fever and major wall lesions. Summary includes rheumatic fever is more of a clinical diagnosis, but nowadays echo and Doppler also have a role. No gold standard diagnostic test, no entity as rheumatic myocarditis. Duration of prophylaxis depends on the high risk. Injectable penicillin is better than oral penicillin, and school and community-based programs required for primary prophylaxis. So time for the recent updates now. So according to WHO, the rheumatic heart disease, the key facts according to the article are rheumatic heart disease is the most commonly acquired heart disease in people under age 25. Rheumatic heart disease and claims over 288,348 lives each year, the large majority in low or the middle income countries. The disease results from the damage to heart wall caused by one or several episodes of rheumatic fever, an autoimmune inflammatory reaction to throat infection with group A streptococci, streptococcal pharyngitis, or streptococcal throat. It most commonly occurs in childhood and can lead to death or lifelong disability. Rheumatic heart disease can be prevented by preventing streptococcal infection or treating them with antibiotics when they do occur. So, rheumatic fever and rheumatic heart disease report by Directorate Journal. So, according to the article published in WHO, the barriers to progress, the main barriers to prevention, control, and elimination of rheumatic heart disease are the neglect of the rheumatic fever and rheumatic heart disease in national health policies and budgets, in the prevention in countries in which rheumatic heart disease is endemic. The paucity of data to enable targeting of the prevention factors, poor primary and secondary prevention and access to primary health care, inadequate numbers and training of healthcare workers at all levels, limited understanding of the rheumatic fever and or rheumatic heart disease is in affected communities, and inaction on the social determinants of the diseases and inequalities in health. Although further researches in some areas is needed, it is proposed that the biggest gap in control of rheumatic heart disease is in implementing effective primary and secondary preventive measures. Rheumatic fever, all you need to know. Rheumatic fever, acute rheumatic fever is a disease that can affect the heart, joints, brain, and skin. Rheumatic fever can develop if streptococcal throat and scarlet fever infections are treated properly. Early diagnosis of the infection and treatment with antibiotics are key to preventing rheumatic fever. Now, time for MCQs. Starting with the first one, non-communicable diseases are also known as the chronic diseases as they are not passed from person to person. They are of long duration, generally slow in progression, and occur from a combination of genetic, physiological, environmental, and behavioral factors. Commonest non-communicable disease in young children 5 to 15 years is A, asthma, B, cystic fibrosis, C, rheumatic heart disease, D, congenital heart disease, or E, stroke. Anyone? So the answer is C, rheumatic heart disease. Question number 2, a 9-year-old girl presented in Peds OPD for the checkup of her presenting complaints. Doctor on duty after taking history has a high suspicion of rheumatic fever in that girl. Which of the following is usually the first symptom of rheumatic fever? A, chest pain or palpitations. B, jerky movements, uncontrollable movements. C, joint pain and fever. D, rash, or E, RTI. The answer is C. Third, rheumatic fever is the inflammation of the joints, heart, skin, and nervous system that occur in children as a complication of untreated sublocal infection of the throat. While most people with rheumatic fever recover, which part of the body may permanent damage in a small percentage of people? A, digestive tract, B, ears, C, heart, D, lungs, or E, eyes. Anyone? The answer is C. Fourth, rheumatic fever is the disease which affect people, heart, brain, skin, and joints. Rheumatic fever can develop if throat infections are not properly treated. Antibiotics are key to determine and prevention of rheumatic fever. A strong correlation of rheumatic fever has been established with A, Staphylococci, B, group A, Staphylococci, C, group B, Staphylococci, D, group A and B, Staphylococci, or E, pneumococci. Anyone? The answer is B. Fifth, for the treatment of streptococcal throat, penicillin is recommended as a treatment of choice because of cost, narrow spectrum of activity, and effectiveness to avoid occurrence of acute rheumatic fever. After streptococcal pharyngitis, penicillin should be given for A, 5 days, B, 10 days, C, 14, D, 28, and E, 25. Answer is C. Sixth, for individuals diagnosed with acute rheumatic fever, the recommended treatment to prevent recurrence and development of rheumatic fever is penicillin G for secondary prophylaxis. Is administered as an IM intramuscular injection every A 1 week, 2 week, C 4 weeks, D 6 weeks, or E 3 weeks. Anyone? The answer is C 4 weeks. Seventh, the goals of the treatment for rheumatic fever are to destroy group A staphylococcal bacteria, relieve symptoms, control inflammation, prevent recurrence. Each of the following drugs is used to treat rheumatic fever in children except A, metoclopramide, B, antibiotics, C, anti-inflammatory drugs, D, corticosteroids, or E, analgesics. Anyone? The answer is A. Eighth, there is no single test used for diagnosis to diagnose rheumatic fever. Doctors look for the sign of illness and a different test. One of the tests that does not predict neither complications will occur nor predict the type and severity of disease, but it is elevated. Its elevated levels may be used to help to confirm diagnosis of the rheumatic fever. A, alpha-1 antitrypsin, B, rheumatoid factor, C, anti-streptolysin, O, D, creatinine kinase, or E, beta-1 antitrypsin. The answer is C. Ninth, the Jones criteria for diagnosing acute rheumatic fever is of fundamental importance. It is has different major and minor criteria, which the following is one of the Jones major criteria: A, pancreatitis; B, fever; C, elevated ESR; D, previous rheumatic fever; or E, rash. The answer is A. 10th, in hospital ward, a patient with rheumatic fever comes with dancing movements characterized by irregular and involuntary movements of muscle groups in various parts of the body. How can you explain the movement? A, myopathy; B, neuromuscular ejection disease; C, stellum chorea; D, psychosis; or E, neuropathy. Anyone? C, the answer is stellum chorea. Here is the key of the MCQs, the references. Thank you so much, everyone. And here is the link of the YouTube channel. Kindly please go check. All the videos are uploaded here. So go like and subscribe them. Thank you so much, everyone, for listening.